Okay, hi there. Welcome to this webinar today. We have got quite a few people coming on board in the next couple of minutes. I'm going to start anyway. We're 5 minutes overdue anyway. So I think we should, I think we've got going to have quite a few more people coming on board. Anyway, for those of you who don't know me, for those of you new here, my name's Dippin. I'm the professional support pharmacist at Pharmacists. And welcome today to this evening's webinar. First of all, I just want to say a big sorry for this for a mix-up that's actually occurred. We were due to do a webinar on dermatology today, and we were going to have a specialist speaker coming in to actually do it for us. The problem was that there was a bit of a diary clash, and we've had to start changing a few things around. So what would have been a dermatology webinar is actually going to be held next month now, and I've had to move next month's webinar for today. So I do apologise if you were expecting something on dermatology, then that's the reason behind it, and I do have to apologise for that. But anyway, we've got what we've got now, and today, as I said, we're going to be going over pharmaceutical care interventions for the elderly and care home residents. And there's a number of things here that I think you need to be aware of. I'm going to be going into quite a lot of clinical content. So if you want to, feel free to interrupt me. It's probably better if you use a chat window initially, and then sort of like I'll be able to put you on the microphone. It will avoid any sort of how to describe it, any sort of issue from occurring in terms of the audio setup as well. So I'm going to move swiftly on. Let's move on. First of all, today I'm going to be going over a number of different things. For those of you who were here last month, you were probably well aware of the fact that we did quite a bit on. Sorry about this. It always does this. That's better. Okay, you're probably well aware of the fact that we did something on QIPP. And now I'm going to be going into slightly more detail on one particular area of the QIPP, and that's known as the antipsychotics. And I'll be going over that in a bit more detail. We're going to be going over generally the sort of diseases that the elderly tend to have, and we're going to focus on falls. We're going to focus on biochemical and drug issues. We're going to look into malnutrition briefly. And the idea today is really to help feed you with some form of clinical content as opposed to just me yabbering on. What we're not going to go over is the following. What we're not going to go over today, we're not going to be going over how to increase your business from care homes. We're going to go over some very briefly with specific examples, but that's not really the objective today. We're not going to be going over things like mark sheets, queries, those sort of things. We're not going to be going over something called the TRANS report, which was a report which was issued around about, I think it was 3 years ago or so, which looked into medication errors in care homes. And we're not looking into things like care home training or turnover either, or staff turnover, that is. Really what we're looking into today is mainly the clinical things, the sort of things that you would want to watch out for in the pharmacy. All these topics we probably will be discussing, but not today. We've only got a limited amount of time today. By the way, I'm hoping to finish off around about 8:45 today. So hopefully you should be able to get away from this reasonably soon. And again, do interrupt me if you do have any questions at all. Now, the first thing I want to show you is something called the Care Quality Commission. And if you're doing some work on a care home or some residents in a care home, it's quite a nice idea to actually look into this particular website. It's cqc.org.uk and search criteria care home. Now, I'm going to click on this and hopefully it will work. I don't know if it will, but let's see. Good, it's going to work. Excellent. Right. This is basically what the website is. And you've got the option of looking into hospitals, care homes, dentists, and so forth. What I'm going to do is I'm going to just type in something here, and it will give you an idea of how powerful this particular search is. So I'm going to putting in the sort of postcode where I live, and that's HA3, and it gives you a list of various care homes. So for example, let's look into this one here. Okay, let's look a little bit further down. Here we go. Let's have a look at Moorfields at Norfolk Park. And what it does, it goes through the standards, and it also gives you an idea of some of the things that the CQC has commented on. So, for example, here it's commented on the fact that this particular care home needs to improve its standards on caring for people safely and protecting them from harm. There are some other things here. If I could, no, not that one. There was quite a nasty one which came up the other day when I was looking at this. I can't see it anywhere, and I can't see it here. But anyway, this particular website is really good if you want to have a general look at how a particular care home in your area is actually doing. So if this particular care home is doing well on everything, there is a possibility that the CQC might be really disappointed with a particular care home, in which case they will effectively name and shame them. I'm trying to find one here, and I can't seem to find one here at the moment, but they will name and shame you, and they'll put a red cross there to say that, here you go, that's one there, is that one there. So that basically means urgent referral. In other words, they've actually taken enforcement action on the standards of management of this particular care home. So it will give you a good idea as to the sort of care homes in your area, and also some of the things that they're doing well and some of the things that they're failing on as well. So just a nice little website for you to actually visit. Now let's go on. Now the sorts of diseases that you'll get in old age. As a pharmacist, I'm sure you're well aware of it. You get all sorts of diseases when you get to old age, but there's several specific ones that are particular for old age. These are, for example, depression, dementia, and we'll talk about that in a minute as well. Cardiovascular disease, so you've got increased risk of stroke, ischemic heart disease, atrial fibrillation, left ventricular failure, and also, I should have put this on another line. This is CKD, which is chronic kidney disease, and we'll go over that in a little bit more detail a bit later as well. And also osteoporosis, we'll be going over that in a little bit more detail, and particularly cancer and terminal illness. And I'm sure you're well aware of the fact that a lot of patients who are old tend to be on painkillers such as morphine and fentanyl, etc., those sorts of things. So these are sorts of diseases that we'll be discussing in a little bit more detail. I'll be starting off with dementia in actual fact. There is one other thing, sorry, I forgot about this slide. There's one other thing that you ought to know about. And for those of you who are versed in EPACT or have done primary care work or of particular interest in this, are probably aware of something called the ASTRO-PU. That stands for, I think it stands for age, sex, temporary residence, and I don't know what the O stands for. But anyway, it's basically an indication as to how much need there is in the population, how much clinical need. And as I'm sure you're intuitively aware, elderly people will tend to require much more need than somebody who is fit and healthy. And what they've worked out, some clever statisticians have worked out, and I don't know how they've done it, but they've done it somehow. It works out that for every elderly person is worth something called 3 ASTRO-PUs. And each healthy person, which is under 65, is worth 1 ASTRO-PU. So in other words, what this is saying is that one elderly person is generally 3 times more likely to have, so not 3 times more likely, is likely to have 3 times more need in terms of prescriptions, in terms of items, those sorts of things, than a healthy person under the age of 65. Now, I'm a little bit, I've done a lot of work on this in the past, and I can probably more or less tell you it's going to be more than that. You're looking at probably more than that, 4 or 5 even. But at the moment, this is the best sort of like comparison that we've got. It's worth at least 3 ASTRO-PUs, but the chances are it's probably going to be worth way more than that, probably about 4, possibly even 5. So really what this indicates is that the elderly counts for a lot of prescriptions, and hence one of the reasons why the government in particular have been focusing on the following topics that we'll be going over in a bit more detail now. So before I carry on, does anybody have any questions that they want to ask? If they have, just put it in the chat window and I'll answer it. Okay, not at the moment. I'm going to carry on then. Now, from last week, you probably remember, not last week, last month even, you probably remember something called the QIPP Objectives. And there were around about 13 or 14 of them. They started off in February 2012. And we had a full discussion on this last month, and it's actually on the website, so I'm not going to go into this in any more detail. But one of the QIPP Objectives was with relation to low-dose antipsychotics in people with dementia. Now, I'm going to be focusing in on this in a little bit more detail. This is actually quite interesting, and it's something that possibly you might be able to do in your own pharmacy. It's going to be a little bit difficult, as you'll probably see, but it's something that you may want to read up on, and it's something that you could possibly even help GPs with. A few years ago, in 2009, there was something called the Banerjee Report. And in the Banerjee Report, they discussed several things, really. I mean, the first thing they stated was that 25% of patients with dementia are prescribed antipsychotics. Now, that's quite a huge number of patients taking antipsychotics. Now, believe it or not, only 1 in 5 of those actually benefited it. So in other words, 4 out of 5 patients did not benefit from the use of antipsychotics, or that they were being used inappropriately. Now, another figure is 1/3 of patients with dementia are in care homes. So you're looking at almost 250,000 people, I think that's how I worked it out, of patients who are in care homes actually have dementia. And the issue here is that too often antipsychotics are used for behavioural problems first line when other measures should actually be used. And when the report looked at this in a lot more detail, and there's actually some Merck bulletins that came out not recently, it's probably about a year or two ago, one of the main causes behind behavioural problems was pain. A lot of patients who are dementia can't express themselves properly. If they're in pain, then they are going to have behavioural problems. And is it possible that, for example, we could use analgesics, if this is the case, instead of antipsychotics, to actually help them with their agitation? This is something that you ought to be aware of. So, for example, can we give tramadol, can we give other sorts of painkillers to actually help these patients who are probably in a lot of pain, and hence the reason why they've got behavioural problems, and hence the reason why they're inappropriately prescribed antipsychotics. Now, moving on from that, we're going to go on to what the NICE guidance actually says now as well. What they have actually said is that the use of antipsychotics in patients should really be limited to when the patient is really, really distressed or severely distressed or immediate harm to themselves or others. It's a second line only, and according to the BNS, any antipsychotic that you use should actually be started as half the initial dose. In other words, the elderly have a much more deeper reaction to antipsychotics than the healthy population, healthy young population, I should say. And if you look in the BNS, it does actually state that you should really be starting these sorts of drugs at literally half the dose, or even less. They also suggested in the NICE guidance that regular reviews are needed. And the thing with antipsychotics generally are that there is also a small increased risk of mortality, of stroke, of transient ischemic attacks, TIAs, hypertension, and hypo or hypothermia, especially if you're in the bath, in actual fact. And top that off with the fact that these are sorts of things that the elderly actually are more prone to anyway. You can probably understand why the Department of Health are particularly concerned with antipsychotics. And some common drugs that you almost will certainly dispense in the pharmacy are listed here. So you've got lanzapine, so that's a spelling mistake, it's quetiapine, risperidone, and amisulpride. There are others, but these are the most common ones that are in use at the moment. Now, that leads to the next question. What on earth can a pharmacist or a community pharmacist do? And it's actually very, very difficult. Because you don't have any of the clinical data, you're not necessarily with the patient all day. In actual fact, you're probably rarely there. You're probably at least, at most probably once every few months you'll be there at the care home themselves, even if that. It's very difficult to make a clinical intervention as such. So the things that you could look out for are keep an eye out for new starters. And also, what you could even do is discuss with the PCT the process that management pharmacists use in order to manage this particular QIPP area. And if the PCT has got it, it might be an idea for you to ask for their audit protocol. Normally what they do, they normally send pharmacists over to GP practices to look at these things. And there's no harm in you actually asking for a copy of that protocol, so at least that way you could be informed about it as well. And you can maybe even have a chat with the care home with regards to QIPP issues. Now there's one other thing you could do, let me go back here a bit. So as a pharmacist, you almost certainly have an idea of the number of patients that are in the care home. So for example, let's say for argument's sake you have 20 patients in a care home, and let's say 18 of those are actually prescribed antipsychotics. Bearing in mind these particular facts, you would expect probably around about 1 in 5 of those patients to actually be of any for those antipsychotics to be of any use to those patients. So really, you would normally expect around about, out of 20, you would probably expect about 4 patients or so to be antipsychotics. If you notice that there are 17, 18 patients on antipsychotics, then you definitely know that something is wrong with that care home or the prescribing in that care home, and you might want to chase it up further. And that's another thing you can actually do as well. However, direct contact with patients, direct interventions with patients themselves are going to be a lot more difficult for you as community pharmacists to do. But you can always get a general idea as to how well the care home is doing in prescribing of these particular drugs with regards to this. So you can get an idea of how many patients are in the care home, how many are antipsychotics, how many would you expect there to be, and then you can work out how good or bad the prescribing is in that particular area. So that really is about dementia and antipsychotics. This is actually a huge topic for the government at the moment. There's going to be lots of money being plowed into this, and it's in your interest, obviously, as pharmacists, to be well aware of this. Now, we're going to be going over another area which is a particular concern to the elderly, and that's called false prevention. There is a lot of nice guidance on it. I'm not going to re-quote nice guidance, but you can quite happily download it at the website if you want to have a read through it. The issue with falls is something called fragility fractures. Now, with the elderly, you've got generally lack of calcium, lack of vitamin D, lack of bone density. That's the reason why they're generally prescribed bisphosphonates, things like alginate, etc. They're much more prone to fragility fractures. In other words, if they fall, they're much more likely to have a fracture than somebody who is young and healthy. Now, why do the elderly have greater risk of falling? There's a few reasons, really. The first reason is that they've got mobility issues. Obviously, they're not as mobile as they used to be, and simply put, they're more at risk of simply just falling down because of that alone. Most of them, or a lot of them, are on diuretics. Now, I'm sure you're well aware of the fact that with diuretics, what happens is you get something called hypovolemia. You might get hypovolemia. In other words, what you could have is you could have too much fluid leaving your body and leaving you with low volume of blood, which could leave you quite dopey and quite drowsy. And also, with the diuretics as well, you could actually have a lot of elderly people rushing to the loo, as well, especially if they're initiated on it. And I know that, when I've actually ended up having to rush to the loo, I've fallen on a couple of occasions. I'm sure I'll be the first to admit I've done that once or twice. And I'm sure some of you might have done the same as well. So these two particular ones are a direct consequence of diuretics. There are antihypertensives. the elderly are much more prone to something called postural hypotension. Basically, what that means is that when you lie down and when you get up very quickly, you tend to feel very, very giddy because the blood effectively is rushing to all parts of the body, and the blood pressure is is lowered is quite significantly lowered when you stand up very quickly. And obviously, if the blood pressure is lowered, you could actually feel quite giddy as a result of that as well. Then you've got these two anticholinergics and sedatives. Anticholinergics can actually make you quite drowsy. They can actually blur your vision at times as well, so that doesn't really help very much. Sedatives, especially drugs such as nitrazepam and the sort of longer-acting benzodiazepines, can actually have a daytime effect as well. So in other words, nitrazepam, for example, is drugs that will tend to last in the body for around about 24 hours. And then obviously you can have some form of daytime drowsiness as a result of that as well. So all these things can contribute to falls. But I'm sure there's others that you can think of, but these are the main ones that tend to be the reason behind it. Now, there is a really good thing that you as pharmacists can actually do to actually help patients with who are more at risk of falling. There is something called calcium and vitamin D. I'm sure you all prescribe it in your pharmacy. This particular intervention can actually increase significantly the number of items that you, as a pharmacist, will dispense in your pharmacy. And at the same time, it's one of those rare things whereby you can increase the number of items as well as do it appropriately. There's clinical guidance there which more or less suggests that almost all patients in a care home, almost all mobile patients in a care home, should actually have calcium and vitamin D supplemented in their diet. Now, there are exceptions, but I'm not going to go into the significant exceptions here. But generally, calcium and vitamin D is ideal for patients who are housebound, patients who are on glucocorticoid therapy, care home residents, and that's what we're discussing here at the moment, patients with osteoporosis, and patients with prior fragility fractures as well. So bear in mind that as many patients as possible in care homes should ideally be put on calcium and vitamin D. I used to do this particular audit in care homes a while back, and it's not uncommon for me to actually put 50, possibly 60 patients in a particular practice, actually even more. Sometimes it could be even up to 200 patients in actual fact, on calcium and vitamin D, simply because the doctor hasn't done it. And you can imagine the number of items that will generate for your pharmacy if you're able to do that. So really, what as you can pharmacists do? What you should do is check the patients who are not taking calcium and vitamin D, and those that are in the categories listed as well. So in other words, you've got your PMR systems, you've got your prescriptions that come in on a monthly basis. Check to see whether or not care home residents, especially elder ones, are taking calcium and vitamin D. Now, what you will also need to do is not everybody should be on it. There are obviously going to be interactions. There's going to be reasons to why patients might not necessarily be suitable for calcium. It could be that they're hyperparathyroid. It could be, for example, that they've got some form of, that they might be taking 1-alpha, for example, or various other conditions. So, there are certain patients who may not be necessarily suitable for, but the majority of patients it will be. And check with the GP, and if it's okay, suggest the initiation of calcium and vitamin D. As I said, it's going to create a huge number of extra items for your pharmacy, and at the same time, it will increase your patient care as well, because these patients should actually be on it. Now, obviously, the PCT may not like this, because calcium and vitamin D is reasonably expensive, because they're going to be on this for the rest of their lives after this. But the idea is, who cares really? It's actually suitable for the patient. It's actually within the NICE guidance as well, and it's actually recommended as well. So this is a really good interaction that you can actually do very simply, just by going over all of your patients in care homes and making sure that they're suitably taking calcium and vitamin D for your pharmacy. So you can actually increase the number of items in your pharmacy quite significantly with this one. And remember what I said earlier, the average practice can have at least 60. I've done practices that have 200, 250 patients. that I've initiated on calcium and vitamin D. Now, this particular subject here is one which is particularly relevant to the elderly, and that is renal function. Now I'm going to be going over a few bits of pharmacology, a few bits of pharmacokinetics, not significantly, don't worry, there's not going to be any maths or anything like that. But in order for you to understand the sorts of interactions that you could actually, as a pharmacist, provide to your patients, you need to have an understanding of something called creatinine clearance, or the eGFR, which is the glomerular filtration rate. Now, what is creatinine clearance? What is eGFR? Now, the two are very similar to each other. What happens in your body is that when your muscles break down, effectively, that creates something called creatinine. And what happens? That actually is built up within your bloodstream. So at any point in time, your muscles are breaking down, they're creating creatinine, which is building up in your bloodstream. This is where the kidneys come in. They actually get rid of that excess creatinine. And the rate at which that creatinine is cleared, i.e. the creatinine clearance, is proportional to your kidney function. So in other words, if you have a poor creatinine clearance, if you have a lot of creatinine in your body, your renal function is very poor simply because of the fact the body can't get rid of the creatinine that's in the body. On the other hand, if it's clearing well, you've actually got a reasonably good renal function. And that is basically what this and the eGFR essentially is. So, generally, with the elderly, your creatinine clearance goes down. In other words, you have much more difficulty getting rid of the creatinine that's created in your bloodstream from the breakdown of these muscles. So this is actually a very good indicator as to how good your kidney function is. Now, I know that's a lot to take in. Do you want me to go over that again? If you could just type it in the chat box and just let me know if you want me to go over that again with you, because that's quite important for you to understand. Okay, I'll go over it one more time. Yeah, there's one person who's actually asking for it. Creatinine clearance is an indication of renal function. The lower the creatinine clearance, the poorer the renal function. And essentially that's all it is. Renal function deteriorates with age. Now, there are stages in kidney disease. There's 1, 2, 3A, 3B, 4, and 5. I'm not going to go over what each stage means. It can, the stages that you particularly need to be aware of is 3, 4, and 5. Obviously 5 being the worst, that is like the kidneys are completely packed in. You're probably going to be on a dialysis machine. 3A and 3B, not too severe, but severe enough to warrant some sort of intervention. So these are the sorts of stages that you're going to be, you're going to want to sort of look into a little bit more detail. The problem is that obviously you don't have creatinine clearance data in your pharmacy. If you're particularly worried about a particular patient, you might want to have a chat with your GP about it, but, the patient's GP, but you're not going to get that sort of information in the pharmacy. But having said that, there are certain medications that you need to be, you need to have in the back of your mind. So if, say, for example, you suspect that somebody hasn't got a very good renal function, there are certain medicines that you need to be much more aware of, and I've got that in the next slide. So these are a selection, in actual fact, these are the majority of drugs that are particularly relevant to the elderly that you ought to be aware of. If they have very poor renal function, then you may want to have a chat with the GP and say, look, you might want to change this over. And I'm going to go over an example of metformin with you in a minute, because that's probably going to be a very relevant one to you. But let's have a quick look through the list. And you've got nitrofurantoin for UTIs. Bizarrely, you've got benzoflumethiazide, and that in itself is a diuretic. Now, the theory behind it is if your kidneys are packed up, what's the point of giving a diuretic? Because it's not going to get rid of any excess water, and that's the reason behind it. The strains, you've got simvastatin, you've got allopurinol, metformin, and we'll go over that. You've got the NSAIDs, so ibuprofen, diclofenac. They also happen to be nephrotoxic, so in other words, they actually damage the kidneys themselves. You've got the ACE inhibitors, you've got digoxin, you've got the bisphosphonates, pardon me, you've got ranitidine, and you've got the antiplatelets, things like clopidogrel and aspirin as well. Now what I'm going to do is I'm going to go into the BNF. Sorry, I've got a question here. Would that be the same for other thiazides too? Yeah, more or less. Yeah. What we'll do is, I'll tell you what, we'll go over the benzomethiazide as well, and I'll go over an example that you would want to be aware of as well. So thanks for that question there. So let's go into the metformin. So I'm going to just log on into the BNF. Okay, I'm just going to sign in, so hopefully it'll let me in this time. Oopsie daisy, that didn't like it very much. Let's try again. Good. Okay, we're in now. Okay, so I'm going to go into metformin. Now, let's have a look. Metformin, here we are. Okay, I'm going to just show you, and I'll give you a couple of examples. This is actually quite an important area for you to understand. So, this is the entry for metformin, and you can look, where is it? Here we are. Okay, let's just highlight that bit there. Lactic acidosis. Use with caution in renal impairment. Increased risk of lactic acidosis. Avoid insignificant renal impairment. NICE recommends that the dose should be reviewed if the eGFR is less than 45 mils per minute, and avoid if eGFR is less than 30 mils per minute as well. So that's an example of interaction, and I'm sure you've got a whole load of patients who are on metformin. That is an example, and I've seen patients, and I've actually reduced doses of patients who are within this range here. Fortunately, I've never had to actually remove one from therapy because of the fact that they're less than 30. They normally would be picked up by the renal unit. But I have actually had patients who I've had to reduce because of the fact that the eGFR was very, very low. I'm going to also go into let's try benzomethiazide. There we go. Let's try that one now. Hopefully I'll have the same sort of thing here as well. I'm not sure, but we'll see. Renal impairment. Here we are. Okay, I think this probably answers your question as well, Rachel. Thiazide and related diuretics are ineffective if eGFR is less than 30 mils per minute and should be avoided. So it's actually a class effect. And if you look at some of the other ones, we'll go over one more because I'm enjoying this now. Let's go over simvastatin. That's another one probably that you're more likely to look at. Simvastatin. Here we are. Let's have a look at that one now. Renal, here we go. Okay, doses above 10 milligrams per day should be used with caution if eGFR is less than 30 mils per minute. So what I would suggest is keep in the back of your mind these particular drugs, so, you know, the ones we've gone over. And as you can see, it's quite easy to determine why a particular drug could actually cause a problem and what you should do as a result of it. So with metformin, for example, you should either reduce the dose or remove it. With benzomethiazide, if it's less than 30, you would actually stop it altogether with the rest of the thiazide. And you'll see similar sorts of entries for all of the remaining ones here as well. So it really is probably within your interest just to keep these in the back of your mind as well. Now, okay, we're coming close to time now, so I'm going to go over some of the other interventions as pharmacists that you may want to look into for patients in care homes. Now, and there's been a lot of issues with regards to atorvastatin being transferred over to simvastatin. This particular presentation was written before the generic version actually came out. That is probably going to go into a decline now. But remember, with simvastatin, there's an issue with the GFR as well. That doesn't necessarily, I don't think that actually is the case with atorvastatin as well. So it's something you just want to look out for. If there are patients being transferred over to simvastatin, just check the eGFR to make sure that everything is okay. But again, you won't necessarily have the data in front of you, but you could keep an eye out for it. There's been a lot of patients being transferred over to low-cost PPIs, proton pump inhibitors. So, for example, from either omeprazole to omeprazole. Clopidogrel. A lot of patients on clopidogrel who are elderly as well. Really, they should only be on clopidogrel if they've got a documented allergy to aspirin. Now, you're not going to know that. That's something that you're going to need to talk to the GP about. But if you notice that somebody's plonked straight up on clopidogrel without having any documented history of aspirin, that's possibly something you might want to have a chat with the GP, because they really should be started on aspirin first, and then if they can't go aspirin, go on to clopidogrel. They obviously use a lot more dressings. So one thing I would suggest is you might want to check with your PCT about if there's any dressings formulary. They tend to have a dressings formula which they're very stringent with. And that's something you could do. And this is an interesting one as well, Cavilon spray. A lot of the PCs have been coming down now and saying ideally they should only be having one per month. And remember, this is one of the barrier sprays for stomas, etc., those sorts of things. And you will probably experience a decline in the use of Cavilon spray. Bizarrely, I'm not sure if you're going to notice that, but I know a lot of PCs are actually looking into that because it's very expensive for them. Glaucoma monitoring. That, if I remember correctly, a significant proportion of elderly patients are lost in the system and do not have their eyes tested for glaucoma. They should be. But again, obviously, if you notice that a patient is on some sort of glaucoma medication, it might be an idea when you have a chat with the care home to make sure that they're having their eyes tested on a regular basis. A lot of patients are actually using aspirin inappropriately, over 75 milligram aspirin. Primary prevention is not recommended anymore for use of aspirin. Now, by primary prevention, what I mean is to prevent it from occurring in the first place. In other words, if a patient has a heart attack or if they've had a stroke or something like that, then that is called secondary prevention, and aspirin is indicated for that. But it's not indicated for the just-in-case scenario. In other words, it's not indicated for for everybody's use. So, in actual fact, it could potentially cause more problems than actually solve. So, you might want to keep an eye out for this. If anybody is using aspirin but hasn't got a history, or if you're not aware of them having a history of a stroke or heart attack or something like that, you can have a chat with the GP and say, is this patient actually appropriate use for aspirin? Bearing in mind as well that a lot of elderly patients tend to be more prone for gastric hemorrhage, and obviously aspirin might not necessarily be suitable for that. You've also got the other ones. You've got laxative overuse, you've got anemia as well, and you've got excessive use of test strips as well. Now that's coming down quite a bit, so I wouldn't worry too much about that. But a lot of elderly patients tend to be anemic as well, and you'll find a lot of folic acid and peristaltic prescriptions for them as well. So those are other sorts of things that I think you just want to be aware of for elderly patients. Now, I think that's it. That's the last one now. Now, the last thing I'm going to go into is something called malnutrition. Now, I'm sure you're well aware of what malnutrition is. It's basically when a person is not getting the nutrients they need to survive. Now, what the PCT is, I'm going to go into something called the MUST tool in a minute, and it's a really good tool which I just want to sort of go over with you very quickly. But what I found is that PCs are very good at removing sick feeds when they're not needed, but they're not good at using them when they are needed. And that goes through the whole board of things. So they're very good at removing people from sick fees when they're not needed, but when they are actually needed, when a patient is malnourished, they're not very good at recommending putting patients on them in the first place. And I'm going to go over something with the MUST tool, and it's something that you could possibly help implement in the care homes. And the good thing about this is that where the PC is actually removing sick fees, it will potentially increase the number of items that you will get as a pharmacist. But again, it's a very appropriate intervention. The thing with malnutrition is that I have a feeling, I'm trying to remember what the actual figures were. I think it was something like 3-4 billion is wasted annually on malnourished patients, while on obesity it's only a fraction of that. No, I think it's about a tenth of that. Or I can't remember exactly what the figures are, but it's a huge amount of money is wasted on treating the diseases caused by malnourished patients. When really what he could have done, he could have avoided that by making sure they're nourished in the first place. Now what I'm going to do is I'm going to quickly go over something called the MUST tool, and it's something that I would suggest, unless you've actually seen it, something that you might want to have a look at. Now, the MUST tool is, you can actually find that at a website called bapen.org, MUST Toolkit. Oh right, you can even get it as an iPhone app now, I didn't realise that, okay. Anyway, there's a lot more information about the MUST tool on the website. We've actually got a CPD document out on it as well. But let me see if I can find, I think it's this one here. Let's try that one. MUST flowchart, let's try that one. Okay, here we are. Now, Zoom, actual site, here we are. Now, what the whole idea behind this is that it actually works out your overall risk of being malnourished. In other words, what it does is you check your BMI score, and you actually get a score associated with that. So let's say, for example, I'm under 18.5 kilograms per meter squared in terms of my BMI. That will put me at a risk of 2. And was that an unplanned weight loss? In other words, was I actually dieting, or was there a reason behind it? If the answer is what the percentage of weight loss was. In other words, if it's greater than 10%, you'll be scoring a 2. If it was greater than 5, so if it's less than 5, you'll score 0. And the whole idea is that what you do is you add these two scores up. And if your score is more than 2 or more, you're actually at risk of being malnourished. So actually at risk, you are malnourished because you've actually got it here. So here you go. If you've got a 0 score, you're low risk. Score 1 is medium risk, and score 2 is high risk. So really, if for example you're here, if you're 2 or more, you really ought to get that patient into some sort of nutritional support. Contact the nutritionist, contact the GP. The problem is, a lot of the time, these patients in care homes aren't actually being assessed according to this. And it could be a nice little way in which you can earn a few more items, but it could also be a very good way of helping ensure that the patients that you are treating are being appropriately prescribed for. And here, for example, you've got a 0, you've got 1, which is a medium risk. So, for example, monitor dietary intake for 3 days, and if adequate, you can read it for yourself there anyway. So it's a very good flow chart that you can use for your own purposes. Now, before I move on, there's one other thing I just want to show you in this, if I can find it. Here we go. I think that's one, alternative measurements. Now, the thing is that a lot of patients are immobile. And what you could do is you can help patients. So a lot of these patients might not necessarily be able to get on some weighing scales. And there are various other ways, for example, you can support the carers to take regular assessments of the patient's BMI. So, for example, I'm not going to go into it, but you can actually do it. You can actually estimate the BMI using something called the ulnar length, which you can get at the website as well. And also you can estimate the BMI from the circumference of the arm as well. So there are other ways that, say for example, immobile patients who may be in wheelchairs, can actually get their BMIs checked. So if they are immobile, there's no reason why these particular patients can't be checked, and there's a very good possibility as well that they could be malnourished as well. In actual fact, I do remember working in a care home, or not me working personally, but a colleague of mine working in a care home, and I think they discovered about 20 patients who were theoretically malnourished and who they actually had to put on some form of feed supplementation. And you can imagine how many items that generated for the pharmacy down the road as well. Now, that's going to be it for today. I think I've just about hit the time. I'm 5 minutes late. But I do appreciate everybody coming on board today. And again, I do apologize for not having the dermatology one. That will be definitely next month unless there's anything else that changes. But we've got an expert speaker coming in, and we're also, the reason why we've got the expert speaker coming in is because we're also launching a funded dermatology service to you lot. And it might be in your best interest as well to attend that one as well, because it will set the basis for the service as well. Just a couple of other things as well before I do sign off. First of all, if there's any questions, please feel free to type them into the chat box. I'm more than happy to answer it in the meantime. Just a couple of things as well. We have got our conference, okay, that's going to be in a couple of weeks' time. Please, if you haven't already joined, do so. It's going to be a weekend one, but if you do want to come for just the one day, then we can arrange for that as well. So please feel free to contact me. If you have any questions with regards to this, please email me at that address, or you've got my mobile number. 754792. I'll just make sure that's not my wife's number, then she'll be pretty annoyed with me. Yeah, that is my number. So give me a ring if you do need me as well for anything, and also if you want to discuss any element of this. It is going to be placed on the website, so if you've missed something, or if you want me to go over, so if you want to go over something again, but can't quite put your finger on the keyboard to actually ask in a chat, then it will be on there probably by next Monday. Alright then, so I'm going to log off now. Oh, sorry. Thank you very much. I've got a few people saying very interested, so thank you very much, no problem. So again, thank you very much for attending, and I look forward to meeting you next month, and hopefully even meeting you at the conference if you're coming as well. Yeah, that's it. I'm going to sign off now, yeah, and I think I need to have a glass of wine down me, and I suggest you do the same. Take care now. Bye.